Good morning. We will start the session on taming the iris in cataract surgery. The first talk is by Dr. Kalaimadi. She is a senior consultant at Giridhar Eye Hospital, Kochi. Over to you, Dr. Kalaimadi.
Thank you, Dr. Sara. My topic is dealing with floppy iris. To begin with, the pupil looks normal, and the iris is, pupil is well dilated to begin with. And when we do the hydrodissection, the pupil becomes constricted, and the iris starts behaving little differently. And this is where we should think that we are dealing with floppy iris syndrome. So why is this important? Why is it important to identify IFIS? This increases the risk of cataract surgery by 5-fold. So it is more associated in men who is using tamsulosin for BPH, and this drug is being used in women for urinary retention as well. And it happens even after a single dose of this medication, and discontinuation of this medication does not eliminate IFIS. So this condition occurs in if the same class of other medicines also is used. Hypertension, diabetes, and antihypertensive drugs like losartan also can cause this condition. And pupillary dilatation less than 7 millimeter, and other drugs like benzodiazepines, antipsychotics, antidepressants, they also can predispose to this condition. So how do you know that it is going to be a problem for you in cataract surgery? There is no perfect way to know that IFIS is going to happen. One of the signs is poor pupillary dilatation. That is the reason why it is called intraoperative floppy iris. So knowing the history is important. The history of tamsulosin use should be asked in every patient. So what is this floppy iris syndrome? Why it can be a problem? So intraoperative floppy iris syndrome, that is IFIS, was described by Chang and Campbell in 2005. It consists of three components, that is iris billowing to intraocular fluid currents, pupillary constriction, and iris prolapse towards incisions. So it is complete if all three features are present, and incomplete when even one feature is missing. So what is our aim during our cataract surgery? The aim is to keep the pupil well dilated and to stabilize the iris. And how can this be achieved? It can be achieved by drugs, the iris hooks or expansion rings, and OVDs. So pre-operatively, we have to use atropine 1% eye drops 2 times daily for 2 days, and NSAIDs 3 times daily for 2 days. So we have to keep all these items ready before surgery, that is adrenaline for intracameral use, oculan, that is lidocaine for intracameral use, and phenocaine, which is a combination of lidocaine, tropicamide, and phenylephrine for intracameral use. And we also should keep ready OVDs like Viscoat or Orocoat, Cohivisc, and HPMC, and iris hooks or B-hex rings. So coming to the surgery proper, it is always better to use peribulbar or subtenon anesthesia instead of topical anesthesia. And small side ports with long intracorneal tunnel is preferred. Here we are using 1 mm clear cut side port knife, and use of intracameral adrenaline is always advised to maintain the pupillary dilatation. And stain the capsule with trypan blue, because in case if the pupil comes down later on, we can visualize the anterior capsule. And the CCC should be at least 5 mm diameter, and the main wound should be 2.4 to 2.8 millimeter incision, and it again should be a long corneal tunnel. And coming to the hydrodissection should be as gentle as possible, and as less fluid as possible in multiple quadrants, so that because it is after this step the cascade of reaction starts and the iris starts behaving differently. The intracapsular bag pressure should be kept minimum always, and the nucleus is nudged, and the trapped fluid should be released, and the mobility of the nucleus should be confirmed. Mobility is confirmed. Now coming to the phaco proper, low flow, low pressure phaco is advised because the main aim here is to there should not be any turbulence while inside the anterior chamber, and the plane of emulsification should be the anterior plane so that the iris should not come out, and minimal in and out movements of the phaco probe should be that should be emulsify, and only then you have to come out so that the iris doesn't come out through the incisions. These are placed over the iris so that it doesn't prolapse out. And it is always better to do a divide and conquer technique. And here the dispersive OVDs are placed, injected first, followed by HPMC beneath it. So while irrigation and aspiration, it can be done either bimanually or by coaxial method. If bimanually, if you are doing the irrigation port should be above the iris, and while lens insertion, the everything should be maintained above the iris plane. The bevel should, it's better to keep the bevel upward so that the iris doesn't get caught in the bevel. If the hooks are used in case of iris, it's better to use 5 hooks, and the 5th hook should be placed below and behind the main incision. This avoids tenting up of the iris and increases the visibility. And in case of iris, sphincterotomies and mechanical pupil stretching should be avoided. If iris gets plugged in the side port, it is better to complete the phaco with that. And if iris prolapses out after the IOL implantation, intracameral meiotic agents such as pilocarpine can be given. While repositing the iris, its gentle pressure should be given posterior to the wound, so that it goes inside, and after that OVD should be placed over the iris to prevent it from further prolapsing. So IFIS remains a challenge for the cataract surgeon always. PCR, the rate of PCR is 7 to 12%, and if adequate measures are taken, it can be brought down to 0. So long-term complications include pupil deformity, which can give rise to glare later on, and macular edema, peripheral anterior synovial formation, and angle closure glaucoma are the common complications. So take-home points are use of preoperative atropine and NSIDs, small side ports with long intracorneal tunnel, dispersive OVDs, and gentle hydrodissection with low fluidics, and anterior plane phacoemulsification. Thank you.
Thank you, Dr. Kalay. So I would like to ask you, we are proceeding with phaco and immediately in midway IFIS occurs. Then how will you proceed?
Okay, during intraoperatively.
Initially we didn't put any pupil expanders.
Okay.
But midway the iris starts billowing and coming out of all the ports.
Yeah.
Then how will you proceed?
Yes, then I'll use the dispersive OVDs. You mean to say the side ports are all bigger? We didn't plan for it. Is it?
The patient was prone for IFIS, but as the pupil was almost 70% dilated, we didn't put any pupil expansion devices.
Okay.
But midway the pupil started shutting down.
Coming down. Okay. So I might try without pupillary, dilatation. If I am not able to do it, then I'll start using iris hooks.
So after capsulorhexis, if you are using iris hooks, what precaution you will take?
I'll inject OVDs between the iris and the capsule, and I'll put the iris hooks.
So
And initially I'll try without iris hook. If I'm not able to do it only, then I'll proceed with iris.
With viscode dispersive OVD, you
Yes.
will try to
Yes.
keep the iris in place.
Yeah.
If we have to inject iris hooks, we should visualize the capsulorhexis margin
Yes.
very clearly.
Yes.
Otherwise, the rhexis can extend.
Yes.
Have you any experience with using atropine pre-op?
I
Does it
tried
help?
atropine, but post-operatively the effect was that the patient was not happy.
Any questions?
So I don't think pharmacodialysis is actually going to maintain the dialysis during the intraoperative manipulations.
Yes, sir.
So my take is, if you are seeing that iris billowing, iris prolapsing through the side port, immediately go ahead and put hooks. If you have already started. If you are doing it primarily before the rhexis is done, I prefer to do a B-hex, provided the anterior chamber is deep, about 3 millimeters. Shallow anterior chamber, I will not use a B-hex. It's very difficult to manipulate. One most important thing is to ensure that there is a hook under the phaco port. Okay, because if that retracts the iris out of the way, there is no iris chafing. The iris itself is very billowy, and it will come towards wherever there is least resistance or wherever there is vacuum. So during phaco, you may feel that it is 5 millimeters, I may be able to manage, but then suddenly it will go into the phaco port, and then you will end up with iris chafing, very distorted pupil, and it gives a very poor outcome, especially if it is a premium IOL multifocal or something like that.
Oh.
So mechanical dilatation is the best way to go for it.
Okay.
So just one more point to add. If the iris has already prolapsed, and when you are entering the eye with the phaco probe, it's better to switch off the flow and then enter the anterior chamber. So that will reduce further iris prolapse.
Thank you.
Thank you, Dr. Kalaimati. Now I invite Dr. Sandhya to give her talk on dealing with small pupil. Dr. Sandhya is a senior consultant cataract at Giridhara Hospital, Edappally. Over to you, Sandhya.
So my topic is dealing with the small pupil. So there is no generalized consensus on the size of the pupil below which phacoemulsification is unsafe. So for most of the experienced surgeons, a threshold pupil size of around 4.5 to 5 millimeter is enough for safe phacoemulsification. So what are the challenges of small pupil? A small pupil can impair visualization of the anterior lens capsule, resulting in a small rhexis, which in turn can lead to difficulty in pulling out the nuclear fragments in case of phacoemulsification, and also getting out the whole nucleus from the bag in small incision cataract surgery. Also, when the rhexis is small, there is increased risk of damage to the rhexis margin, and which can go beyond the equator and can produce a wraparound tear of the posterior capsule. There is also increased chance of retention of cortex and nuclear pieces in the bag, and suboptimal visualization can cause difficulty in placing the intraocular lens inside the bag. So because of more manipulations, there is increased release of prostaglandins, which can exacerbate the postoperative inflammation and cystoid macular edema. So pupil can be expanded pharmacologically or by mechanical methods like viscomydriasis, synecholysis, pupil stretching, sphincterotomies, or by the use of pupil expansion devices. So preoperative use of NSAIDs can sustain pupillary dilatation and can also reduce the incidence of intraoperative meiosis. Combination of cycloplegics like tropicamide and adrenergic receptor agonists like phenylephrine and adrenaline can be injected intracamerally to dilate the pupil. Combined intracameral use of mydriatic and local anesthetics like preservative-free 1% xylocaine can be used in topical anesthesia. So in this patient, intracameral adrenaline was used to dilate the pupil. And then a high molecular weight OVD was injected in the anterior chamber and also within the pupillary margin to cause dilatation of the pupil and deepening of the anterior chamber. So in this patient, if the pupil is not very small, you can get an adequate size rhexis even without the use of pupil expansion devices. Here 2 to 3 strokes of the rhexis can be taken out, and then you have to bring the apex of the rhexis within the pupillary area, and then again take 2 to 3 strokes outside and then bring it within the pupillary area. So we always should bring the apex within the pupillary area in between, because with continued force outwards, the rhexis can extend to the periphery. So this should not be attempted if the pupil is very small and if the lens is intumescent, and also if there are features of IFIS. So what are the prerequisites for pupil stretch and use of expansion devices? So maximum preoperative pharmacological dilatation should be attained. Anterior chamber should be filled with OVD to maintain AC depth and pupillary dilatation. Any synecdoche and pupillary membrane should be released. And very small and rigid pupil should be stretched before using these expansion devices. So in this patient, there was an organized membrane covering the entire pupillary area, and there were posterior synecdoche. So there was a gap between the iris and the organized membrane through which a thin iris repositor was introduced, and the organized membrane was released from the pupillary margin. And then OVD was injected under this membrane, and from the other side port, rest of the synecdoche and pupillary membrane were released. Now there is a thick band there which could not be released, and it was cut by using microrhexis scissors. So once all the synecdoche and the membrane were released, iris hooks were used to expand the pupil, and then phaco was completed. Now in this patient, mechanical stretching of the pupil was done. So anterior chamber was filled with OVD, and 2 Coughlin hooks were introduced, and the iris was stretched diagonally. Now the aim is to produce micro tears at the pupillary margin, sphincter tears at the pupillary margin, but you should apply uniform force and should not stretch the iris too much, because that can cause tearing of the iris. So this is useful in case of post-UVT cataract and also in rigid pupil. Also, while taking out these Coughlin hooks from this area, that is the extreme periphery, you should take care not to cause DM detachment. And this is applicable in many cases, and it is relatively simple. And in this patient with black cataract, where a small incision cataract surgery was done, iris hooks were used to cause pupillary dilatation. So whenever you are using trypan blue in case of small pupil, it is better to go under the iris and inject trypan, so that it will stain the periphery of the capsule, and you will have a good visualization later when the pupil expansion devices are used. You should also irrigate excess of trypan blue so that it doesn't leak out from behind the iris and obscure the view when rhexis is made. So 4 equidistant paracenteses were made here. That is, you should make these paracenteses at the posterior limbus, and they should not have a long corneal tunnel, because in that case it will cause stenting of the iris, and then the manipulations will become difficult. So these iris hooks have got a silicone sleeve, so that should be retracted, and it is inserted inside the eye, and the iris is hooked. Once it is hooked, you can tighten the sleeve. So after insertion of the first hook, subsequent hooks insertion are easy because the iris is already lifted up from the anterior lens capsule. You can also inject little OVD under the iris margin so that there is space between the anterior lens capsule and the iris. Then you can adjust the size of this pupil by further tightening or loosening the sleeve at the end. Here the cataract is black and it has a huge nucleus, so we want a really large rhexis here. So a very large rhexis was made, and then a large scleral tunnel, that is 1.5 millimeter from the limbus, was also made. And here the entire nucleus has solidified. So while doing hydrodissection, it was very difficult to insinuate the cannula between the capsule and the cataract. So hydrodissection was done by injecting small amount of fluid at multiple places. And after a good hydrodissection, the upper two hooks were released before the nucleus was taken out. So you have to retract the silicone sleeve and make the hook parallel to the iris and then take it out. Nucleus rotation was ensured, and then using two Sinskey hook, the nucleus was taken out of the bag. The left hand Sinskey hook is going under the nucleus and it is retracting the rhexis, because there is high chance of bag also coming out along with this large black cataract. So the lower Sinskey hook was used to retract the rhexis margin, and then the nucleus was taken inside the anterior chamber, and then using traction counter traction method it was delivered. Then after IOL insertion, before taking the OVD, we need to remove these hooks, and then pilocarpine was injected. Now this is Malugin ring is a square shaped decide made of polypropylene, and it has got 4 scrolls, and this comes in a preloaded manner, and it can be withdrawn into the injector. Now after filling the all these devices should be inserted after nicely filling the anterior chamber with OVD. The distal and the 2 side scrolls got engaged at the time of insertion itself, and these can be inserted through even 2 millimeter corneal incisions, and the proximal scroll was engaged using a Sinskey hook. Now this Malugin ring, it produces a round shaped pupil because it has got 8 points of contact, 4 at the regions of scrolls and 4 in between these scrolls. So it produces a pupillary dilatation of around 6 millimeter, which is adequate for most of the phaco cases. Then these are relatively stable rings, and usually it doesn't hinder with our surgical manipulations, and it doesn't get dislodged very easily. So one more thing is that it's available in 2 sizes, that is 6.25 and 7. Now when we are using these rings, it is very important to chop down the nucleus into multiple smaller pieces so that it can be pulled out of the bag without disturbing or dislodging these rings. So if it is very large piece, then while pulling out, you can disturb the ring. So a lens was injected, and this ring, the scrolls were disengaged from the pupillary margin using the Sinskey hook. This should be done before removing the OVD, and it was totally freed and kept in the anterior chamber. And using the same injector, it can be withdrawn. So you have to hook it like this, and then pull it into the injector. You can use an iris repositor to guide the retrieval. And then usually these rings do not damage the sphincters. So at the end, you will get a near normal pupil. So this is B-hex ring. It is a uniplanar hexagonal ring. It has got 6 flanges on the sides and 6 notches. Then alternate flanges have got holes in it. So after filling the chamber with OVD, there is a specialized 23 gauge forceps for inserting it. The B-hex hooks can be inserted through with that forceps, and then the flange with the hole is carefully placed under the iris, simultaneously taking care to hook the 2 notches also at the pupillary margin simultaneously. And if you want to release it, you can use an iris repositor also. And the last flange can be placed under the iris through the same paracentesis, or you can approach it through the opposite paracentesis. You can use the same 23 gauge forces also for this manipulation also. And this gives an pupillary dilatation of around 5.5 millimeter. And since these rings have a vertical thickness of only 0.1 millimeter, it can be used even in patients with relatively shallow anterior chamber also. And it can be inserted even through side ports with 1 millimeter size. And then after nucleus emulsification, cortex removal was done, and then using the Sinskey hook, these rings were released from the pupillary margin. You may get some pigment dispersion, mild pigment dispersion, when you are taking out this hook from the pupillary margin. And then it is very flexible, and you can just take it out through the incision like this. Now in this patient with small pupil, Inova ring was used. This Inova ring is a silicone ring that is from Orolab, and it's a circular ring, and it has got groove on the side for uniform expansion of the pupil, and also it has got 4 positioning hole, and these should be engaged at the pupillary margin. It comes in a preloaded form, and you have to just go 2 holes, one here, one hole, and through that OVD can be injected. And then after like IOL insertion, this can be injected into the anterior chamber. When almost 3/4 of the ring is inside the anterior chamber, it can be pulled out, simultaneously withdrawing the injector. So this is a relatively bulky device compared to other devices, but gives a larger pupillary dilatation of around 6.3 millimeter. So then these positioning holes should be carefully engaged at the iris margin using the Sinskey hook. And so you will get a relatively larger rhexis when we are using these. But since this is bulky, so when you are introducing your phaco probe and all, there is a slight possibility of disengagement of this ring. So after then lens removal, the ring was disengaged, and then you have to keep the iris repositor beneath, and then a Sinskey hook can be placed in that positioning hole, and then just withdraw it from the anterior chamber. So compared to hooks, all these devices will give a relatively physiological pupil at the end, because damage to the sphincter is minimal with these devices. So to summarize, we have various options to expand the small pupil during cataract surgery, and choosing the appropriate device in different clinical scenarios will give optimal outcome. Thank you.
Thank you, Dr. Sandhya, for clearly explaining the principles to use during small pupil. Now I invite Dr. Matthew Kurian, Senior Cataract Surgeon, Chaitanya Eye Institute, Ernakulam, to deliver his talk on dealing with intraoperative positive pressure. Over to you, sir.
Thank you, Dr. Sara, for having me. So this is something that happens infrequently, and the most important thing to remember is to recognize it. Because if you fail to recognize it in the early stages, you will be losing the opportunity to manage the condition without too many complications. So central and peripheral shallowing of the anterior chamber happens, and because you're doing it from an en-face view from the microscope, you may not realize how anterior it is. You may end up with side port, main port, or any other instruments either hitting the capsule or the iris. So commonest cause is aqueous misdirection, where normally the ciliary body is rotated posteriorly. There is adequate space to for the fluid to go through the angle, but here it goes into the Berger space and pushes the lens iris diaphragm entirely forward and causes a pupillary block. So this results in a flat anterior chamber, angle closure, and eventually raised IOP, which needs to be managed. UBM is the best way to detect this, where there is anterior rotation of the ciliary body. The angle is completely occluded over here. The ciliary body, which is back there, is now rotated forward, and the iris cornea angle is close to zero. Management options. If it is aphakic or pseudophakic, you can just go and either limbal or pars plana, you can enter into the Berger space and withdraw the fluid, which is a little bit of a guesswork, unless you have intraoperative OCT or something like that. Or you can do vitrectomy, either anterior approach or a pars plana approach. So what they say is that preliminary vitrectomy is to debulk the vitreous and soften the eye, phacoemulsification to be performed subsequently, then finally complete the vitrectomy with the zonular hyaloidotomy and peripheral iridectomy, and you want to create a single anterior posterior segment space. So that is the PI is done, and through the PI MVR blade is introduced to go through the zonules, and then the anterior vitrectomy cutter is passed posterior to the capsule. Make sure that you are not damaging the capsule, and do a limited core vitrectomy. Little bit dicey situation, and I will explain why. So this is one of the cases that I had. Fairly high hyperopic IOL powers, axial length is small, and I had done the left eye, the smaller axial length eye, without too much of difficulty, and I was now doing the right eye. So let's see what happens. Iris is billowing, iris, this is viscote I had placed already, and during that time also iris billowing, and during IA the iris is prolapsing out. Again put viscoat to tamponade and try to prevent the iris from prolapsing out. And then medium-sized nucleus, but phaco was proceeding pretty much uneventfully, and I thought, okay, I managed this, no problem. Okay. Folds on the posterior capsule, and then it becomes hard, iris is prolapsing, side port also is plugged. I thought I'll release the speculum pressure, whether that is the cause. Not much use, viscoat is coming out, hardly anything is going in. I have to put the IOL inside, pushed in anyhow. Okay. Leading haptic goes into the bag, optic opens, trailing haptic is in front of the iris and does not go in. So then I thought I'll do this cut down method, and by the time patient is experiencing pain, wincing and all that, 1 millimeter behind the limbus, just make a small peritomy and try to do a sclerotomy. Some blood oozes out and I think, okay, this is going fine. Try to reposit the trailing haptic into the bag, not working. Rather than create a PC rent, I decide I will go and do this limited anterior vitrectomy in the burger space. So I am cutting and cutting. At this time glow was still normal, but now glow starts to alter. And you can see the retina is, entire thing has come up. So at this stage, quickly abscise whatever remaining of the iris is there. Patient is wincing, very uncomfortable. Somehow suture it, even though there is little bit vitreous, iris there, small heme coming there, inside the anterior chamber, close, get out. So what were my learnings from this? Hollade says that it is not just long, normal and short eyes. There is also proportionately smaller anterior chambers, normal anterior chamber and large anterior chamber, and about 9% are short, out of which 2% have got a proportionately crowded anterior chamber as well. Challenges in the longer one are much less, and the risk of intraoperative hard eye is very much higher when you have a small or crowded anterior chamber, maximum being when the anterior chamber as well as the axial length are both small. So let's look back at my first patient. So here the axial length was small in both eyes, okay, so that is short axial length. But in this eye, the white to white was more than 11. So in the shorter axial length, the white to white, so the anterior chamber was not as crowded, and so this was axial hyperopia, while this one with less than 10.75 millimeter white to white, it was actually a non-ophthalmic eye. So what are the intraoperative challenges in non-ophthalmos? We have to look at these things to realize that it is a problem there. During our biometry, we never look very closely. We just look at the IOL power and forget the rest. Intraoperatively, shallow AC, viscoelastic appropriate. Consider a tap, but I am not very convinced about that in all situations. Sclerostomies. Surgical risks are expulsive hemorrhage, uveal effusion, or malignant glaucoma. So recognizing this is the most important thing. Everything is small in the anterior chamber, and there is a high lens proportion is much larger when compared to the rest of the eye, and there is increased retinochoroidal scleral. So today all patients with a short eyeball undergo a B scan, and we measure the retinochoroidal scleral thickening. Phaco in anterior chamber, all the basic steps: perfect wound, anterior place wounds to prevent iris prolapse, use heavy molecular weight viscoelastics, protect the cornea, increase the bottle height if required, raise the IOP, low vacuum, low flow rate, and do a spiral or double rhexis, use a microforceps for that one. The special considerations: Anything less than 22 millimeters, I ask for Diamox preoperatively. Anything less than 20 millimeters, I ask for Diamox plus mannitol pre-op. Prefer to give a good block, because if things go wrong, these patients experience pain as the expulsive is happening, and so they will be very uncomfortable, and they will strain and worsen the problem. So prefer to have a block, but after a block, give a very good digital massage, adjust the phaco parameters, consider the appropriate IOL power. Pars plana vitrectomy is supposed to preempt the choroidal detachment and creating space in the anterior chamber. I am not convinced by that. Sclerotomy is what I prefer, especially if the retinochoroidal complex is thicker, more than 1.9 or something like that millimeters, is better to have it pre-prepared and ready. Why does vitrectomy precipitate a choroidal detachment? That's a normal eye. Here you have some amount of effusion going on, and if it was a ECC kind of thing with an open wound, it will proceed all three posteriorly also, and then you get the altered blow as your first warning. But today we are operating in a closed chamber, and that doesn't happen often. So at this stage, if you decide to go and debulk the vitreous pressure comes down, but there is no amount of pressure you can put over here to push everything back, the lens iris diaphragm back. So what happens is, this is already under tension. It is like you have released the weight on the pressure cooker, and that converts the incipient expulsive to a frank expulsive hemorrhage. So what does sclerotomy do? It allows this to drain out. And in a closed chamber, you don't get the posterior thing happening. What will happen is ciliary body area blood collection rotates the ciliary body, AC becomes shallow, and glow will continue to be good because it is not gone up till here, because you are operating in a closed environment. Okay, so sclerotomy is what I would suggest. And the sclerotomy technique to perform is 1 millimeter behind the limbus, 1 millimeter incision, which is basically a radial incision, and you can use just your side port or something itself to keep cutting down till you see the brownish uveal tissue. You don't necessarily need to use a punch, but you need to create a space there and cause the blood to flow out. And my present thing for this condition, which is acute intraoperative rock hard eye syndrome, is differential diagnosis is aqueous misdirection, which we would like to happen, but which happens much less frequently than we believe. And we believe that expulsive can never happen to us. It happens only to other people. Okay, so think that it is expulsive that's happening to you. Prevention is better than cure. Diamox and mannitol preoperatively, like I said. Have the high molecular weight OVD ready. Have a sclerotomy ready. If you are not comfortable doing yourself, get a glaucoma colleague to do that for you. And treatment, fight to live another, live to fight another day. Okay, so don't try to be heroic that day. Close, put sutures of all main port, side port, everything. Put the patient on mannitol and plan for secondary safe completion, either later in the same day or on another day. If you want to do any tap or vitrectomy, you have to have proof that there is no expulsive, otherwise you are in trouble. Thank you.
Thank you, sir. I just have a doubt, sir. Is there any increased risk for aqueous misdirection in people who have got coloboma, iris coloboma, where the zonules are weak? Or
so in terms of all patients with a lax zonule can potentially have fluid going back. So what I would suggest in cases like a coloboma, where you know that there is one area of weakness, you put viscoat. No financial interest there, but viscoat is, don't use anything else. Use viscoat, plug that area, seal that area, and especially if you are planning to do staining of the anterior capsule, it will prevent the trypan from going to the posterior segment and altering the glow. So plug that area, then you are okay.
thank you, sir. Next talk is by Dr. Sara on repair of iris defects. Over to you, Sara.
Good morning. Repair of iris defects. The proximity of iris to the instruments and currents of cataract surgery and the fragility of the iris tissue make it prone for iatrogenic damage. Iridoplasty is the procedure of reconstructing the defective iris, while pupilloplasty reconstructs the pupil that has an altered configuration. So, before proceeding to iris reconstruction, we should evaluate the patient's visual symptoms and cosmetic concerns and the extent of iris tissue loss. Iris sphincter damage can occur, mid-peripheral damage of the iris can occur, and iridodialysis can occur. So, this is a picture of a diffuse sphincter damage in which the pupil is widely dilated. The salient points in iris tissue repair is the initial assessment is important. We have to use, before suturing, intraoperatively, we have to use the microsurgical forceps to approximate the tissue to determine how the iris behaves, whether the iris is elastic, whether it is scarred, and keep the AC always formed intraoperatively with OVD or if needed with an AC maintainer. It is important to release adhesions of the iris and peripheral anterior synechiae, if any, to mobilize the iris and oppose the flaps of the iris without excessive crowding or tissue loss. And the preferred suture is the non-absorbable one, that is the 10-0 or the 9-0 polypropylene. We will consider first the iris sphincter damage. Always suture the functioning iris sphincter to the functioning iris sphincter. So we have to map out where the iris is functioning. The iris sphincter is functioning. So in slit lamp, by increasing and decreasing the light, we can know which part of the iris sphincter is deficient. And intracameral acetylcholine can be used intraoperatively to see which part of the iris sphincter is constricting and is functioning. Normal orientation of the iris is radial except for the central area. So if the central sphincter is lost, the adjacent radial orientation of the adjacent area of the iris is disrupted. Here we can see that the radial orientation is disrupted. So McCannell was the first, in 1976, first described the iris suturing. But this procedure had little disadvantage in that the iris had to be pulled out of the paracentesis. So the iris was pulled out, the knot was tied outside, and the iris and the knot were reposited inside. So it caused lot of traction on the iris, and it could be used only for peripheral iris defects. So modified McCannell technique came. Here the suture is, the knot is tied externally and the iris is not pulled out, it is staying there itself, and the knot is tied externally, and using end opening forceps, the knot is brought inside and also the iris tissue is approximated intraocularly. So this is a better technique. The Ksos sliding knot technique was a revolution in the case of iris suturing. Here, a sliding knot is passed into the iris, into the eye through a paracentesis. So, here the knots are created externally and no intraocular instruments are used to tighten the throws. So, this has reduced the intraoperative complication. So, we will see a model of the Ksos sliding knot technique. Here, the Ksos configuration is arranged. This is very important. So, the top suture is the one that passes through the distal paracentesis. The middle suture is the one that passes through the distal iris, and the bottom suture is the one that passes through the proximal iris. So, this is the Ksos configuration. We have to understand the Ksos configuration to do all the types of Ksos sliding knot techniques. So, this is a single pass 4-throw pupilloplasty being done. So, a 10-0 polypropylene suture is introduced through the paracentesis, and micro forceps is used to grasp the iris and pass the 10-0 proline suture The AC should be well formed with cohesive OVD so that endothelial trauma doesn't occur. And then the microforceps is used to grasp the distal end of the iris, and a 26 gauge needle is introduced through the distal paracentesis, and the railroading technique is used to bring out the tensuro suture. So the suture passes through the both ends of the iris. Then a loop of the suture is brought out, and 4 throws are made through the loop, and both ends are tightened. So 4 throws are actually made, and both ends are tightened, and the suture ends are cut with an intraocular scissors. So this technique was described by Dr. Amar Agarwal and Dr. Priya Narang. So we can see the single pass 4-throw pupilloplasty in the model. The loop of the suture is brought out, and the Seepser configuration is arranged. The top one is through the distal paracentesis, the middle one is the one through the distal iris, and the bottom one is the one through the proximal iris. So 4 throws are passed over the middle suture. This has the advantage that only one pass is needed. In the first Seepser model which I showed, it was a 2-1-1 variant. So here only there is a single pass and 4 throws, and the 2 ends are tightened. This is a stable helical knot, but more tension is needed to approximate this iris ends when compared to the 2-1-1 variant. So that is a slight disadvantage of it. This is the iris cerclage technique. When the pupil is widely dilated because of extensive sphincter damage, the iris cerclage technique is better. But it is a more challenging technique, and multiple paracenteses have to be made, and the suture passes through the first paracentesis, and a running stitch is passed through the edge of the pupil, and when passing the sutures becomes difficult, the suture comes out through the next paracentesis, and a better ergonomic position is attained, and then the next running suture is placed. Likewise, 360 degree, the running suture is placed, and the 2 ends are tied. This is iris cerclage technique. When mid-peripheral damage occurs, if the area of iris loss is less than 2 clock hours, we can approximate the both ends of the iris by the Seepser sliding knot technique or the modified McCannell technique. Now coming to the iridodialysis repair. So 2 main types are there for iridodialysis. The first is the hang-back technique or the non-appositional technique. Here a double-armed tensiroproline suture is taken, and it is introduced through the paracentesis, and it passes through the iris root and comes out through the scleral tunnel that has been made 1.5 mm away from the limbus, and the second needle is passed through the paracentesis, and similarly 1 clock hour from where you took the first bite, you have to place the second arm of the tensiroproline suture, and it passes through the iris root and through the scleral tunnel, and both the needles are cut and the suture ends are tied to form a mattress suture. So up to 3 clock hours of iridodialysis can be managed with this technique. The advantage of the hang-back technique is that overcrowding will not occur of the angle. We can titrate the pulling of the iris. So this is a video of iridodialysis repair being done. Here to is the pass of the 10-0 proline needle. A 26 gauge needle is used to railroad the suture out. So the first needle is out and viscoelastic is injected, and the second arm of the needle is again introduced, and it is again docked. And brought out. So the two suture ends can be, the needles can be cut, and the suture ends can be tied in the 2-1-1 configuration. So the two suture ends are being brought out. Why we are using a scleral flap is that to prevent late suture erosion. So you can use either a scleral pocket or a Hoffman pocket. The second technique of iridodialysis repair is a sewing machine technique. Here a long 25 gauge needle or a 26 gauge needle is used. The 10-0 proline suture is threaded into the needle, and then multiple passes are made through the iris root and the sclera, 1.5 mm away from the limbus. And so you have lots of loops coming out, and at the end the loops are all cut and the adjacent suture ends are tied to give multiple mattress sutures. That is the sewing machine technique. So to conclude, the fragility, proximity, and at times flaccidity of the iris makes iris trauma an inevitable part of our surgical journey. In the last two decades, there has been many improvements which have resulted in better outcomes in iris reconstruction. Thank you.
Thank you, Dr. Sara. That was an excellent presentation. One new thing that has happened is that Dr. Vivekanandan and Aurolab have developed this new flanging techniques and special spatulated needle, and you can use that to do iridodialysis tear repairs very easily, and it's available as a kit including the cautery device from Aurolab. No financial interest there again. Thank you.
I would like to ask Dr. Matthew, if the iris prolapses when putting the first paracentesis, how will you proceed?
At that stage itself, I would leave it like that. I would go maybe 180 degrees opposite and try to make another paracentesis, which would be a longer tunnel coming a little more into the anterior, towards the center of the anterior chamber, and decompress. And once I have decompressed, I would it would allow the prolapsed iris to fall back into the chamber. Then use a heavy molecular weight OVD to push back the lens iris diaphragm. Then plan for 4 or 5 hooks if it is such a shallow anterior chamber. If it is a deep anterior chamber, I prefer to use the B-hex ring.
Thank you, sir. Any questions from the audience? I think we will wind up the